Good morning, everyone. Thank you for joining us. We're going to give people just a few minutes to come into the webinar, so we'll get started shortly.
Good morning, friends.
Good morning,
Good
Allie.
morning. Nice to see you.
I know. Good job, Leslie. Sorry I didn't log into your system yet. Oh.
We'll talk later. I'm excited to meet when we're done.
All right. Well, thanks everybody for joining us. As always, I'm Dan Milner, a consultant pathologist with ASCP and a co-host of the Africa Calls and Project ECHO program that, as you all hopefully have heard, we are now doing in collaboration with the American Society of Cytopathology. Dr. Leslie Lomo has been running Africa Calls, and she's now been joined by Dr. Ali Lowe from Stanford from ASC as a co-host for the cytology related activities. Today's session is the first Project ECHO cytology session. We haven't done one of these before, and Dr. Lomo has put together a demonstration of that. I've already reached out to many of you as volunteers, and I know that we have about 8 or 9 volunteers to do cases for future echoes, so this should be a very exciting process. So today I'm going to let Dr. Lomo do the echo, and we hope to see you on many future calls. Leslie, go ahead.
Thank you very much, Dan. I have to give a big shout out to Dan Milner, his team, and ASCP, obviously, for supporting this new joint effort, combining the classical Africa Calls cytopathology series now with a Project ECHO component. And as Dr. Milner mentioned, I'm now joined by Dr. Ali Lowe at Stanford, who is a representative of ASCP. And so as my partner in crime, co-coordinator of this joint effort, I'm very excited to launch this first session. And so what we would like to do is for this inaugural session of Cytology ECHO is to put forth to you sort of our overview of what we envision, what we would like to see with this series. Then I will proceed with the format, which would be a didactic session, and then I'll give 2 case presentations, and these are just examples, and what I'll be presenting are sort of loose guidelines in terms of the details. And so let's just brush over the overview. And so in terms of the conference structure itself, essentially, it will mirror what is already occurring for the histology echo, which means that there is an introductory didactic presentation by a subject matter expert, followed then by 2 15 or 20 minute or so presentations by audience participants. And I'm thrilled to hear that there's already been volunteers coming forward. That is just fantastic. And then what we would like to have is question and answer and open discussion after each segment, because this is for you, the participants. Yes, we are delivering information in one direction, but we want to hear comments, questions in real time, and then get feedback later, which I'll touch on in just a minute. We've already talked about the participant recruitment. It's amazing, people have stepped forward already. There are 2 dates in December and April. And then in terms of the structure of the presentation itself, these are just guidelines, but I think it would be helpful if there is available relevant clinical information. What when you select a case and want to present it, did you have any pertinent technical factors or challenges with the technical aspects of the case? We would love to hear that. Your assessment of the morphology, the differential diagnosis that you came to, and the final classification that you arrived at, if possible. And then, as I mentioned, we are working on a systematic way to collect feedback, because again, this is for you, the participants, but we also want to learn from you, and we want to find out ways that we can make the sessions, of course, delivering up-to-date information, but in a way or in a focus that is really going to help you in your practice. And also, we would like to hear about future sessions, what you would like to see. So let me pause here. I think that you can put information or questions in the chat or the Q&A box. I don't know. I haven't seen anybody pipe in there yet. Let me just take a few seconds and see if anything will pop up, if anyone has any questions about what I have talked about so far. Okay, so I'm not seeing anything, but I will rely on the panelists and others to alert me if anything will arise. So I'm just going to then proceed to the didactic portion. And so for this part, what I thought I would select as the first topic, if you will, is an area that I think is timely, relevant, and that most, if not all of us, can relate to, because it can be quite challenging, whether or not you have access to, even if you do have access to additional ancillary testing. And that is focusing specifically on peritoneal fluids. And when one is faced with a cellular sample, that one is concerned about neoplasia. And so what I hope to do in this session is to facilitate your learning or reinforce your pre-existing knowledge about common technical preparations of body fluid specimens that have been submitted for cytologic examination. And then I would like to discuss diagnostic challenges in a very focused, specific diagnostic area. Now, as you are reading through this, what I will say in the interest of full disclosure is that in addition to being a cytopathologist, when signing on the surgical pathology service, my focus is on breast and gynecologic pathology. So now my bias is revealed. So just a quick talk about preparations of body cavity fluids. And so when I mean fluids, they include ascites from paracentesis procedures or actively obtained pelvic washings for staging for gynecologic oncologic processes. And so at our institution, if a particular fluid specimen is received already fixed, then what our laboratory does is prepare 4 cytospin slides. And then they are alcohol fixed and pap stained. If the fluid specimen is received fresh, then 3 cytospins that are alcohol fixed and pap stained will be prepared in addition to an additional air dried, diff quick stained smear or cytospin and a cell block preparation. So I just wanted to pause here and note that techniques will vary from group to group and institution to institution based on preference of the pathologists and resources and et cetera. And so in terms of cell block preparation techniques, I know that this has come up previously in Dr. Vanderland's session last year, in Dr. Chandra's session also. And so I'm just going to touch on it here. Common cell block preparations include plasma thrombin clot, a collodion bag, histogel, and cellulant, and then there are others. So I'm not going to discuss that further. That's a topic for additional discussion at a little later time. But if you put in the chat or reach out in another way that requesting more information, we'd be glad to get that information out to you.
Dr. Lomo,
Yes.
on the fixation or specimen in a remote site, possibly, could you give some examples for the different fixation methods or liquids that are used?
Oh, well, that is a great question. And I don't know that I have the best answer to that. Would you have any thoughts on that, Dr. Lowe?
Oh, I was just curious if that,
Okay.
because I
Yeah.
think with what we have seen sometimes is some Cytolite preparation that was used for various specimens outside of thin prep usage, but that's not to endorse that specific company. And I can also look into seeing the other methods of just kind of alcohol type fixation. And so I was curious if your institution, when you received a fixed specimen, what it was.
Oh, okay. Yes. Yeah. In terms of our institution here, I will confess, I don't actually know that off the top of my head. I know I get a mixture of slides. Oftentimes we have preparations that come first in when the slides come out as SurePath or Thin Prep. But in terms of in remote settings, I don't know that. And so it would be interesting to hear from our audience participants what challenges they face. And actually, Dr. Milner sounds like he can pipe up.
Yeah, so there are a couple of methods. So Ron Balassanian at UCSF has developed a method using formalin and the cells and pelleting that works quite well. And I can get that protocol. I think for a future session, either for the echo or for the calls session, we might do a whole focused area on cell block preparation and production. If the audience would like to hear that, give us that feedback and we can do that. But I know Ron has one that they developed for Peru, which just uses formalin. There are things like histogel that you can get, which histotechs will tell you they either hate it or they love it, which allows you to embed a block inside the gel pellet. There's the plasmon thrombin approach, which is the pricier approach, and usually works pretty well. I don't recommend that for rural settings, or low resource settings. But my suggestion would be that we think about a future session on this, and maybe we can have Ron Balassanian come and talk about that, because that is his area of expertise.
That's excellent. Thank you for that brief discussion. I think that is really critical, and I wanted to touch on it, but I knew that I wouldn't have the space to discuss that here, but thought it was important to point it out. Okay, and so in terms of accuracy of body fluid cytology, the sensitivity in detecting serosal malignancy varies, but up to 71%. But in terms of false positive diagnoses, the rate is very low. And we are cautioned to beware of malignancy or even neoplasia when we have background underlying conditions in the patients that we are looking at, from infarction to chemotherapy, all the way down to established cirrhosis, which is really important, because that would be a not uncommon scenario to encounter. Okay, so what I thought I would do to start off with the discussion of these diagnostically challenging areas is to do it in a case-based format, because I think that is more interactive in terms of engaging the audience and so on. And so the cases that I'm going to present are ones that I have been involved in or have encountered in various settings here in my practice. The first case is of a 59-year-old female presenting with increased abdominal girth and imaging studies showing ascites, omental caking, and a 29-centimeter unilateral ovarian mass. So as a GYN pathologist, when I see this, I'm thinking that it's probably going to be gynecologic and it will likely be serous. But of course, they're serous in histotype. Whether it's a low-grade or high-grade process is not clear. That being said, of course, there are cancers, gastrointestinal, for example, that can show, obviously, high volume ascites and peritoneal deposits, abnormalities that will show up on imaging. And so I don't have data on the serum tumor markers, such as CA-125, because this was an outside case that was sent to us for routine review for a patient who was transferring here for treatment. And on the gross description, what we are told is that at the thoracentesis procedure, 1,600 ml of dark yellow turbid fluid was removed. And so I just showed a couple of representative high power shots here. One of the diff-quick stained, air dry diff-quick stained cytospin, as well as an alcohol fixed pap stained cytospin. And you can see here that if these are mesothelial cells, these are large, relatively discohesive cells with irregular, sort of eccentrically placed nuclei that appear on the diff-quick stain to be quite darkly staining, with abundant cytoplasm that is microvesicular. And so while it may look quite alarming on the diff-quick impression, on the alcohol preparation, alcohol fixed preparation, yes, it is still cellular. There's some mesothelial cells probably here and here, and we have these clusters of glandular cells that well, they're in clusters as well as present singly, that now that we're able to look at the chromatin pattern of the nuclei, seem blander. The chromatin is more evenly distributed. There are distinct nucleoli, but they all seem to have relatively the size is within a narrower range. So the cytological findings can be summarized by hypercellular preparations with enlarged epithelioid cells in clusters and singly. The atypia is present, but it is on the milder spectrum, and we see cytoplasmic vacuoles. Obviously, I didn't give you a low power view, but I am telling you that there was no background extracellular mucin to suggest perhaps pseudomyxoma peritoni or some process like that. So just on the morphology, we could entertain differential diagnosis that, well, I suppose you could have mesothelial cells. Mesothelial cells can have cytoplasmic vacuolation. But if they are reactive, they will tend to look, their nuclei will tend to look a little bit more uniform. And then if it's a neoplastic mesothelial process, then you will have extremely cellular samples with tightly cohesive, almost morular-like clusters. So here, there are a few clusters, but there's a lot of single cells here. And so for me, what I would gravitate towards would be a metastatic adenocarcinoma, such as from the GYN tract, ovary, or endometrium, perhaps the clear cell carcinoma, although the nuclei quite aren't in that category with the crinkled nuclei and hyperchromasia. Breast is in the differential, as well as clearly the GI tract. So we were able to observe that a cell block preparation was prepared. Again, here is another view at the alcohol fixed preparation, pap stain preparation at the top here for reference. And in the cell block preparation, we find more cohesive clusters that kind of have a more accentuated bumpy border here, if you will. Again, the nuclei are irregular, but they're not pleomorphic. This is not high-grade cytological atypia. And so we do have these clusters, but we also do have individual cells here. And then some of these clusters have occasional fibrovascular cores. And then there is the presence of these Samoma bodies. So in thinking about metastatic carcinomas that are associated with Samoma bodies, we can think about thyroid. I think that that's quite unusual. I don't know that I've ever seen a case of metastatic thyroid carcinoma to the peritoneal fluid. And obviously, mesothelioma would enter in the differential morphologically. Although when you consider the initial clinical presentation of omental caking in the presence of a dominant ovarian mass, again, I will be gravitating towards an ovarian, a gynecologic origin, and would be favoring a low-grade serous neoplasm. Okay, so in terms of trying to sort out, so if we just step aside from this case for a moment and think about what the potentially the quality of the cytologic changes are in fluids that are of a low-grade nature, and we're coming across this differential of low-grade serous neoplasia and mesothelioma, there clearly are morphological clues that we can turn to. So for mesothelioma, as I've alluded to, these specimens are highly cellular, both in single cells as well as tight cohesive clusters. They will often have a very spherical or morular type morphology with a knobby contour. When you are viewing the nuclear changes across all of the different cells, whether they're single or in clusters, there's a spectrum. There tends to be a spectrum of change, and then the classical feature of windows formed in between the mesothelial cells as they are because of their interlinkages, having that absent space from the villi interdigitating would be present or visible on the cytologic preparations. And that's in contrast to serous neoplasia. If you've got a low-grade process like a borderline serous tumor, then the clusters are tightly cohesive, but they will have more irregular borders, either papillary projections or micropapillary. And then when you are trying to sort out, okay, I have a background of mesothelial cells versus this highly atypical or this atypical population, this distinct population, it appears to be a separate population from the background mesothelial cells, and you would not see windows. And so, but it can be very challenging. So this is a case of a mesothelioma that has these rounded structures and fibrovascular cores, very bland nuclear features, and some homobodies. And so it may be that in a subset of cases, well, it likely is possible. It likely is true that in certain cases, it is extremely difficult to be able to make that definitive call just on the morphological features. So for those individuals who do have access to cell block preparations, morphology on the cell block preparation may assist. Especially if there's micropapillary type of architecture that we see with a micropapillary variant of serous borderline tumor. But if there's also access to immunohistochemical stains, then employing the epithelial specific keratins would be very important in ruling in a serous tumor. PAX8 would be very helpful with strong positivity, as well as estrogen receptor positivity. WT1 would be shared between, would be positive in both serous tumors as well as mesothelioma, but serous phenotype would be negative for the other mesothelial markers such as calretinin and D240. Now, what happens if this is the reality? You have to make the call on the morphology, as Dr. Chandra had alluded a little bit to in his session. And the key is, if you feel that the findings are hypercellular, there's a distinct population, that this is a low-grade neoplasm, then positive for neoplasm, favor, and then whatever you are inclined to favor based on the morphology. And at least that will give the clinical team an idea of how to proceed next. Now for mesothelioma, we would expect that there would be other risk factors, asbestos exposure, et cetera. The challenge is if you would have a primary peritoneal serous process, that can be very challenging, meaning that the adnexa, the fallopian tubes, ovaries, they show no signs of dominant involvement. And so then the diagnosis of exclusion then would rest then on a primary peritoneal process. So that can be challenging. So let's return back to this particular patient because this is really interesting. So she went back, so the initial procedures that she'd had obviously was a therapeutic paracentesis, and then she proceeded to undergo staging surgery, which included a bilateral salpingo-oophorectomy in addition to a total hysterectomy and a debulking. And it turns out that both of her ovaries were involved by a heterogeneous process. So in many of the areas, there was complex architecture here with fibrovascular cores and so on. But that then were in areas lined by pseudostratified epithelium with moderate cytological atypia that is in keeping with a borderline tumor. But then in other areas, there was mildly increased cytologic atypia and destructive stromal growth. And so what the final classification turned out being is a low-grade serous carcinoma arising from a serous borderline tumor. And here is a higher power view to show the cytological features. And these are atypical. They're not pleomorphic. Maybe you could consider moderate, but pretty much this would be classified mainly in the low cytologic atypia category. And then if we take a higher power view of the area of the serous borderline tumor versus the low-grade serous carcinoma, you could argue that there is qualitatively an increase in cytologic atypia in the low-grade serous carcinoma part, but there is overlap. So then the question is, can you comfortably say that all of the lesional cells in the fluid is of the low-grade serous part or the serous borderline tumor part? So what complicates things is that if you are in the first scenario where you receive a fluid from a patient who has not had a prior diagnosis, and you see this neoplastic process and it's low grade, and you are confident that it's serous, you cannot make the distinction between a serous carcinoma, a low grade versus a serous borderline tumor in fluid specimens. It's analogous to in the thyroid, for example, thyroid follicular lesions, because it requires assessment of stromal invasion. Although they are not classified as carcinomas, borderline tumors are staged as such, at least in the US. So for example, if you have a borderline tumor that is confined to the ovaries and there's no other disease elsewhere and your washings are positive, that will positive for neoplasm, even though there's no carcinoma there in the borderline tumor, this would upstage the patient. So ensuring, if you don't know if there's carcinoma or not in the mass, the dominant lesion, then if you are receiving a low-grade neoplastic epithelial process, you're confident it's epithelial, then it's best to classify it as neoplastic cells present, either consistent with low-grade serous neoplasm or consistent with involvement by the patient's serous neoplasm. If the resection specimen happened to be concurrently reviewed, you can say serous borderline tumor. What ends up happening is that in some institutions, the cytology and the surge path are signed out by two different divisions or sections. And so then if the cytologist signs it out as positive for adenocarcinoma, and all you have is a serous borderline tumor, now you can see where even that terminology will cause confusion among the clinical team. So it's best to sort of keep things consistent unless you have an opportunity to review the surgical pathology specimen. And so now to complicate things further, according to the WHO classification of tumors, serous serous borderline tumors can have a number of very early invasive changes and still yet be considered to behave indolently and be treated conservatively, such as a serous borderline tumor with microinvasion, in which you have cytologically distinct cells. They acquire a little bit more eosinophilic cytoplasm. They can be single cells infiltrating the stroma, looking like in lacunae, even in lymphavascular spaces. But these foci are less than 5 millimeter in any single focus, and there's no desmoplasia. So that's serous borderline tumor with microinvasion. Then you can have a microinvasive low-grade serous carcinoma, where again, the vast majority of the tumor is actually a serous borderline tumor, but you have at least, you have multiple foci that morphologically appear to resemble a low-grade serous carcinoma. So there's an increase in cytologic atypia, but these foci, which are associated with a stromal response, measure less than 5 millimeter in any given focus. And then you can, as probably all of you recall, you can have a serous borderline tumor without any invasion in the main mass, but then the implants can be classified in various ways, such as superficial, non-invasive, with or without desmoplasia. So it may appear to be an invasive process, but it's yet laying on the surface of the ovary or the peritoneum without destructive invasion underneath. Or you can have invasive implants and yet it still be classified as a serous borderline tumor. So I will pivot a little bit and let that sink in. I'm sure that I will I welcome questions and comments. It is a challenging area, but again, the reason behind all of these distinctions is because it is known from outcome studies that serous borderline tumors behave indolently compared to low-grade serous carcinomas, and even definitely more indolently than high-grade serous carcinomas. And so now, if you're faced with a cellular neoplasm that you are comfortable appears to be serous in nature, and you're trying to, now you have to grade it, usually there's not a diagnostic issue between low-grade versus high-grade, because high-grade serous carcinomas are frankly malignant. So here's an example where you can see at low to intermediate power how pleomorphic the cells are typically. They can vary quite significantly in size and shape of both of the overall volume of the cell, as well as the quality of the nuclei, the size and the quality of the nuclei. Versus a low-grade serous neoplasm. And so if you have access to immunohistochemistry, here's where the P53 staining will be helpful, because serous borderline tumors will have a wild type pattern of protein expression versus a high-grade serous carcinoma, which is associated with mutations in P53 that will either result in strong diffuse positivity, which is overexpression, versus completely absent staining. And so that is where the morphology correlation with the protein phenotype or the phenotype comes into play if you're trying to sort something out. Okay, so then the next step is, okay, you have a high-grade lesion. Now, is it high-grade carcinoma that is native to the GYN tract, or is it a high-grade carcinoma from elsewhere? And so in the absence of ancillary tests, then what we can turn to is working knowledge about what are the most common tumors associated with malignant effusions based on gender. And then obviously it may vary from geographic region to geographic region. And so that's when we are now going to rely on our practice-based learning and just our experiences working clinically, right? But it could be expected that ovary and endometrium. GYN would be heavy hitters, as well as breast, and then other organ systems. And so then we could try to consider in each of these different subtypes, then what are the expected morphological features if we think about breast metastatic to the fluids? Is it an invasive ductal, which will be cohesive, versus a lobular carcinoma, which would be discohesive? And then by analogy in the stomach, could it be a signet ring cell type versus the conventional high-grade adenocarcinoma, and so on. So, okay, so from that, I think what I will do is pause here and see if there are any questions or discussion. I'm not seeing anything, at least from my view, in the chat here, but maybe Dr. Milner has access. Actually, let me see.
So one question that has been posted so far in the Q&A was about specimen preparation staining. So about PAP staining versus right MGG type staining. Yes.
To be stained in the right stain, as there's no PAP stain in the area. Ali, could you, MGG, could you just?
I think that's a right GIMSA based type staining.
Oh,
as well,
I see.
like a diff quick or a hemacolor stain.
Yes, there's no PAP staining. Yes. I think that is probably advantageous. Right stain, well, the diff quick is a modified GIMSA stain, if Ali could correct me if I'm wrong, but and so that's the most convenient, that you would be able to have something that is air dried very, and would happen very quickly, and then to stain it with these types of Romanovsky type stains, I think would be helpful. And if you can implement that in the area, that would be very helpful. One of the advantages about cytology, obviously, is that there are many different preparations that one can use, but also then one has to learn what are the characteristics of various processes with these different stains. And with the diversity of normal, reactive, and neoplastic lesions out there, it can be a lot. But diff quick is a great starting place. And so that would be a great way to start. I know that there's also rapid PAP techniques as well, but obviously that that would have to that would require some resources as well. And Ali, I don't know if you do anything with rapid PAPs or anything like that in your practice.
We do not have a rapid PAP in my current practice, but I did have some experience with it when I was training at UCLA, and it did still take about 15 minutes for the rapid PAP, which is at least shorter than a conventional PAP and doesn't require any instrumentation. So we could still hand stain with the rapid PAP. So in that way, it did still facilitate pretty quick review of fixed slides. Alternatively, in the past, I've also used fixed slides and stained them with an H&E frozen section type stain. So the main differential I think of is if you're air drying your slides, then you can use the Romanovsky GIMSA type staining, which is often just less than a minute for staining and doesn't require any fixation other than air drying. But then fixed slides, we use either kind of a rapid H&E or a rapid PAP or a conventional PAP. So it's a little more resource intensive, but then you get that fixed morphology with the nuclear features as opposed to kind of the stromal and cytoplasmic staining qualities that you get with the air dried. So just as you were saying, having those different preparations help facilitate review of different characteristics of cells. Yeah.
Then I'm just going to squeeze in one last thing to see. Are you familiar with toluidine blue? I mean, have you encountered that? Because I think that's another very rapid way to stain slides, but I don't have any expertise with that, but I know that it allows very rapid initial view, but then you have to stain it you still have to stain it later.
Right. Yes. So my experience with that is very limited in a research setting, but it was an even more rapid stain than the Romanowsky-Giemsa type stains. And it does have a little bit more limited morphology, but you can get a general sense of the nuclear detail, size mainly, not so much chromatin texture or how fine or coarse, and then the hyperchromasia is more subtle, I think, on that. But you get some sense of cytoplasm, but it's still really not as good as the Romanowsky-Giemsa type. So it's really more presence of nuclei, almost the size of the nuclei that you can make out, but really not much cytoplasmic detail. Yeah, that's a great question too.
Thank you. And so I'm just trying to interject all of these so that then our audience can hear the diversity of options that can be available to people. And, we look forward to exploring that and bringing them up so that the audience participants can explore them as they wish, if they wish, and we would love to help them. Okay, so now what I'm going to try to do is, I know I'm probably running quickly on time here, but I selected 2 cases. These are not necessarily going to be similar to what we would like audience participants to select, so that they might be a little bit different than what the audience may select. But I just decided I would select them, to present them here, and then use them as, again, a jumping point that to set the stage, to introduce different aspects, and hopefully throughout the year, either as part of the Africa Calls series or with the subsequent echo sessions, that we can touch on different points that perhaps might resonate with some of the audience participants. So the first case, we are fortunate in terms of getting clinical information that she is 51 and she was diagnosed a few years ago with breast cancer of her, on the left, that was also associated with a lymph node metastasis. The phenotype, so we were able to get information on the phenotype. It was diffusely positive for estrogen and progesterone receptor. It was not, it did not overexpress HER2 by immunohistochemistry, and the grade was a grade 2. So I know that practices vary. It can be very challenging when perhaps you encounter a patient for the first time and they give you history, but there's really not much else that you can glean. But when available, it really is critical. I try to extract this information as much as I can, because why hold yourself back? I mean, I think having that information is so critical to make sure that everything is in alignment if you have that information available. So I know that I'm not going to be considering a potential single cell process unless the report says with lobular features, for example. I know what to expect in terms of the immunohistochemical panel. And so this patient underwent neoadjuvant treatment followed by lumpectomy, showing residual carcinoma and sentinel lymph node biopsy with negative nodes. She was non-compliant, unfortunately, with the recommended anti-endocrine treatment because she did have an ER positive and PR positive tumor. And then she came to my attention because I was evaluating her peritoneal fluid. So she had represented recently with GI symptoms and increased abdominal girth. And then on the scans, in addition to progression of known bony metastases, she had bilateral adnexal masses. Now, of course, it's entirely possible that, this is just going to, this will be recurrence or metastasis by her primary, but it's also possible that she could have a synchronous, concurrent ovarian tumor process, the breast and ovarian cancer syndrome. So paracentesis was performed. She had large volume, but the interventional radiologist submitted an aliquot. In this case, it did contain diagnostic cells, and so it was modestly cellular, but there's some inflammatory cells here. I don't have any mesothelial cells here for comparison, but these have increased nuclear to cytoplasmic ratio, and maybe, well, obviously this is a larger cell, and it has intracytoplasmic vacuoles with almost like targetoid type inclusions here. So in this view, it does look a little bit discohesive. We were obviously able to get a cell block preparation where some of these cells were clustering, but we have enough cells here to immediately say that this is malignant, right? And because we've got intracytoplasmic vacuoles here, this is an adenocarcinoma. And so then the question is it a MET or is it GYN, or is it from elsewhere? And so, but with this this history, then of course we would lean on this being a metastasis from her breast primary. And so in the presence of access to special stains, this tumor was strongly positive for GATA3, and the cell block preparation, the cells also were strongly positive for ER and PR, and HER2 is negative. So I just wanted to point out here, I know that Dr. Milner was mentioning about the plasma thrombin method, being challenging, a little resource intensive. And in fact, you will want the fluid to be fresh. So you'll need to have fresh specimens refrigerated, because alcohol fixed preparations, the alcohol in the fixative will interfere with this plasma thrombin clotting mechanism. And so so anything that comes in fresh, as I alluded to at the very beginning of the presentation, if it's fresh, then the laboratory will make a cell block preparation for us, which will then be processed as a routine tissue block in formalin. So any immunohistochemical stains that are performed on that sample have already been validated as for formalin fixed paraffin embedded tissue. And so with, as we know, with ER, PR, and HER2 testing, that is a top concern. And so then thinking about, okay, this is a grade 2 in her past, invasive ductal. It is a little bit more discohesive here, but this is GATA3 positive, it's ER and PR positive, and HER2 1+, which is identical to her original. So this is consistent with metastatic disease from her primary. So what are some common cytologic patterns in neoplasms? I'm sure this is a review for most, but just for completeness. So when I'm looking at a process fresh, naively, and I see an abnormal subpopulation, and it clearly appears malignant or neoplastic, is it cohesive or discohesive? And if it's discohesive, then immediately I will be thinking about a number of entities. And now we can go down each of the different pathways that I'm sure it is well known to this audience in terms of the nuclear and cytoplasmic features. Background is important, especially with in evaluating something that you may suspect could be signet ring cell. If there's a lot of mucin, I've had the opportunity to diagnose one of those in my, at least one of them in recent time. For the first time in that particular patient, they were presenting as malignant ascites with mucin and signet ring cells, very hypocellular sample. So that has to sort of be on your radar if you see a lot of extracellular material. Prominent nucleoli would make one think about certain entities like prostatic adenocarcinoma, of course, melanoma, seminoma, cytoplasmic vacuoles, et cetera. And then plasmacytoid is a big one, right? So especially if it's discohesive and plasmacytoid, of course, it could be hematolymphoid, but then looking at that chromatin and asking, was this finely dispersed pattern? Could this be a neuroendocrine neoplasm? I've come to sort of think of them, neuroendocrine lesions in the category of melanomas and lobular carcinoma and so on, you know, those kind of things that fly under the radar, that, you know, you always want to say, well, if I've excluded everything, have I really excluded everything? And sometimes going back and saying, you know, could this be a neuroendocrine neoplasm? It may help. So as we've alluded to before, by looking at the morphology, obviously having the history is helpful, but in the absence of that, really drilling down on the nuclear and cytoplasmic features is really helpful. And that's the starting point. That is my my North Star, obviously. And I think, you know, most of us will really heavily still rely on the morphology and then use that to direct us, if we have access to it, to a specific subset of stains. The ones that I've highlighted here are transcription factor related. So these are nuclear stains and are very robust. But of course, depending on the type, there are other robust markers. Actually, TTF1 should be highlighted as well. So I'm just putting that for completeness. And so what are some of the potential challenges in this case that this case raises? When we talk about breast cancer, of course, pre-analytic is at the top of our list, right? When we're thinking about what is the truth about the protein expression of the sample that we've received, and was there anything that was in our control or not within our control? And if it was within our control, did we do everything in our power to make sure that the specimen was appropriately handled and attended to before we processed it, and so on? So what is interesting to note is that often we'll get these large volume samples from these therapeutic paracentesis, for example, you know, a liter or so. And of course, as I mentioned, you know, they should be refrigerated, but it doesn't need fixative. So the fluid itself will preserve the cells relatively well, even when the fluid is unfixed, as long as a specimen is refrigerated. Some of the other challenges, especially when, you know, for example, CSF, I mean, we've gotten cases of, yes, can you do ER, PR, and HER2 on, you know, this case from a breast cancer patient that you called positive for cancer in her CSF? And, you know, it really, depending on what fluid you're looking at, you may only have very rare cells. So the reliability of testing, on the reliability of testing on very few cells, if that's all you have in your sample, that is the reality of it. And finally, assay reliability may be concerned if the sample that you've received is alcohol fixed and the clinician still wants to have the testing performed on it. So then you have to ensure that you include that caveat if you move forward with that testing, if the testing was not in fact validated on alcohol fixed preparations. Okay, so any questions here? I'm just looking very quickly.
Additional that I see. Yeah.
Okay, perfect. All right, so I'll keep moving just to make sure we finish on time. So I have two little mini cases here relating to the same thing. And now we're going to pivot a little bit to cervical cytology. And I will completely acknowledge that the vast majority of findings that we are dealing with and concerns is going to be cervical squamous cell carcinoma, predominantly HPV associated, but we mustn't forget HPV independent entities, and also GYN lesions from floating down from above the cervix. So this first case, I actually had very recently, 57-year-old female, no clinical history, and just an ICD-10 billing code of Z12.4, which I believe corresponds to routine screening. So this recapitulates what we see quite commonly, you know, no history, no last menstrual period, menopausal or premenopausal status, et cetera. And so we really are dealing with what is just in front of us and the age. So no other specimens were previously reviewed that we had received in my institution here. A thin prep pap smear was created. And at first glance, this person likely has atrophy. We've got just these scattered fragments of sort of sheets of immature or kind of epithelium here. There's no maturation and kind of a hypocellular background. So in fact, I was a bit concerned that this may be unsatisfactory, in fact, until I went to higher power and I was kind of scrutinizing some of these little bits here and asking myself, is there something else going on in the background? So just a higher power view of one of these large, thick fragments, very uniform. While there's no maturation, these nuclei are very even, chromatin, smooth nuclear borders, and so on. But then some clusters, there was scant cytoplasm, or they were basically bare nuclei, and there were some distinct nucleoli and very crowded, tightly clustered. Some of them were just really on top of each other. And so I will admit, and I'm sharing this with you humbly, that I wasn't sure what was going on here. And I was concerned still with potentially, maybe, I don't know if that was degeneration or necrosis, maybe from atrophic vaginitis or something like that. But I wasn't sure what to make of these cells. So aside from the hypocellular background and the question of adequacy, I was concerned about these cells. There is atrophy in the background, and now with this morphological category of hyperchromatic crowded groups, then we could think, is this endometrial cells? Is it, in terms of the glandular category, is it endometrial? Is it degenerated endocervical? Is it coming from elsewhere? Or maybe is it squamous? Is it a high-grade squamous intraepithelial lesion? I didn't feel that this was squamous. I favored that this was glandular. And then the question is raised, is it benign? If it's benign, is it reactive? Is it degenerating? And then what would be the mimics? And I think probably endometrial cells or just degenerated squamous cells is probably sort of what I was playing around with. And if it is neoplastic, if I was concerned that that is neoplastic, could be it's cervical, extracervical, or extragynecologic. The bottom line is I wasn't sure. So what are some of the things that I could have done with the hypocellularity? We could get a repeat preparation, additional studies. So some laboratories can do a cell block preparation on the fluid, but it's important to be aware that P16 can be strongly positive in this context in entities other than an HPV-associated lesion. So for example, a high-grade serous carcinoma of the endometrium can be strongly diffusely positive for P16 by a non-HPV-associated pathway. And so we'll want to make sure if there is some concern, then obviously knowing the high-risk HPV status, if that's available, would help clinch that. And then other resources, consultation from colleagues, et cetera. Whether right or wrong, I felt concerned enough about it to call it atypical glandular cells. I favored neoplastic. I favored extracervical origin. So what are the challenges? So Dr. Jost, when she was talking about quality, right, was talking about the challenges of, if you have very limited information or missing critical information for cases, that can really hamper optimal assessment of a case. This was an external client, so unlikely to have follow-up based on my recommendations. So essentially the follow-up for this patient would be endocervical and endometrial sampling. And so, was this an overcall versus could I miss, undercalled something of concern? And so this next quick case that I just wanted to squeeze in here is that of a case I had some time ago, a 66-year-old female with postmenopausal bleeding that occurred after she had menopause 15 years ago and presented for evaluation, including a pap smear and an endometrial biopsy. So in this case, it was hypocellular. It was relatively scant, but as I was going to higher power and scrutinizing, there were these, so here's metaplastic cells, and these are very large, highly concerning cells with macronucleoli. Here's this cluster of very atypical cells. And here it almost, is this a squamous cell? Is this a spindled cell? It wasn't clear. But the endometrial biopsy came soon thereafter, and you could see that there's this biphasic proliferation, including a glandular, a villo-glandular type architecture here, and then a stromal component, which I think maybe you can appreciate at low power. There are big cells in here, and there was a malignant stromal and a malignant epithelial component, which was high grade. And so this was an example of endometrial carcinosarcoma. So these so-called type 2 or non-endometrioid, non-hormonally driven carcinomas in postmenopausal patients can occur in a background of atrophy and potentially could be shed. And so that's something to think about when you have a hypocellular sample from a postmenopausal patient and a background of bleeding. We want to make sure that, yes, maybe there is a cervical cancer, but in a patient who's HPV negative, then maybe something is more sinister is happening outside of the cervix. So extracervical gynecologic malignancy is something to think about when you see atypical glandular cells, a limited number of them in a relatively clean background, unless there is direct extension to the cervix of the mass. The morphology will be dependent on the uterine type, endometrioid versus non-endometrioid. And as I mentioned, we want to avoid using P16 and rely on high-risk HPV testing for a definitive answer in these cases. And so differential diagnosis of the hyperchromatic crowded group is going to be different if you have squamous versus glandular lesions. And then clean background would argue for an intraepithelial versus a more necrotic background would argue for more invasive process. And then if you've got glandular component, then obviously, yes, think about adenocarcinoma in situ, but it could also be extra gynecologic if it's a much older patient. And then we all know about benign sources of glandular atypia, which I've included here. Okay, so I think that wraps it up. I am a couple of minutes over, but I don't see any additional questions, but I'll pause here and see if any of the panelists or Dr. Milner, Dr. Lowe, or anyone else has any comments that they'd like to share before we conclude.
Yeah, so just for the group, so this is our first cytology echo, and Dr. Lomo obviously gave a wonderful presentation with these great cases. How the format will go for when you volunteer is that there will be a brief didactic, probably about 10 or 15 minutes, and then that person will stop, and then the individuals will present their cases, and they'll have about 15, 20 minutes total, including questions to do that. So when you think about your cases, as Leslie said, do consider cases where you have a problem, cases where you learned something, cases where you think others might learn something, or cases that are extremely routine that you have workflow problems around. Any of those are really great for discussion. And I really appreciate Dr. Lomo doing the demonstration today.
Yeah, I'd love to hear that kind of thing, so that then we know how we can tailor what comes subsequently that might be more helpful to this audience. So if there's no other comments, well, we will go ahead and conclude. Thank you to everyone for attending, and again to Dr. Milner and his team for having us, and we look forward to seeing you next time. Take care.
Thank you so much, Dr. Lomo. Wonderful job.